Hello, today we're going to be covering the concept of contraceptions. So in general, what is contraception? Contraception is a method of preventing women, from becoming pregnant. So this is generally used by people who want to delay pregnancy, not become pregnant at all, or they have some contraindication to pregnancy, such as maybe peripartum cardiomyopathy. Now there's several methods. Nothing is 100%. But they are divided by their efficacy. Tier 1 is methods which have a failure rate of less than 1%. Tier 2 are contraceptive methods that have a failure rate of about 2 to 3%. And then finally, Tier 3 have our basically the barrier methods, and they have about an 80% success rate. So this is how they're divided. Now generally what goes in each column. For Tier 1, these are going to be your invasive strategies. So this is going to be your intrauterine devices. This is split up into Mirena and copper, which we'll talk about in a little bit. Then you have your DMPA, which is a progesterone implantation. And then you have Implanon, which is this is a subcutaneous one, and then finally we have sterilization methods, which is actually can be this either from the female side, it could be tubal ligation, or from the male side, it could be a vasectomy. And these all have a great chance of working, 99% in most cases. With Tier 2, here we're talking about primarily hormonal. First, you have your oral contraceptives. And oral contraceptives are split into two groups, either combination, which is estrogen plus progesterone, or just progesterone only. These are the two methods. However, these are given in different forms: pills, patches, and rings. So, and also just to point out, DMPA and Implanon are progesterone types. However, since their efficacy is really great, it's going to be under Tier 1, and they're just kind of a more invasive type of just regular progesterone that's here. Finally, Tier 3 is all your barrier methods. This is going to be including your condoms, your diaphragms, and your spermicides. And so this just is going to prevent implantation through physical means, and this has some advantages as well. It can prevent certain diseases, STDs, from occurring, and you can even cervical cancer from HPV as well. So let's first tackle Tier 1 and the Iuds. So how do the Iuds work? Well, Iuds is something that's going to be some type of device which is implanted. I mean, here's your uterus here, and here's the fallopian tubes, and then you got your fimbria here and your ovary on this each end, and then this is going to be the cervix right here, and then you have your vagina. So IUDs are two types primarily, Mirena and copper. These are, both of them are actually have a plus, make a T symbol, and Mirena actually, we start writing this down. So we have two main types, Mirena and copper. Mirena actually will secrete levonorgestrel, and this is and so levonorgestrel will be secreted from this, and this is a type of progesterone, and this has three effects. The first effect that it has is it thickens the cervical mucosa. So what that means primarily is this area right here is going to be really much thicker. And how does that help? Well, if you have the sperm trying to get through, it's very difficult for the sperm to do any penetration. So one of the ways that it works is it decreases the sperm penetration. Now, not only does it work on the sperm, but say for example somehow the sperm made it all the way up, it caused fertilization. It also causes thickening of the endometrial wall, right here, this becomes much thicker, and so it's going to be very difficult for the blastocyst to implant here. So what it also does is it's going to decrease blastocyst implantation. And by the way, these two are both brought on about this, and you're going to probably notice that you know, even in the tier 2, they thicken the cervic mucosa, and you're going to get this as well. What's more unique to the IUDs, however, is that they also have effect on the cilia that's in the tube. And you know, you would think that it would decrease the rate, but actually what it does is it increases tubal motility. And so how does that decrease fertility? Well, in order for it to, you know, for the, let's just say here's a, gets fertilized and the blastocyst implants. In order for it to implant, it must be in the blastocyst stage. But if implants, say for example it's here, it's still in the morula stage, or you know, even less, maybe the 16 cell stage, and it can't implant. So by moving too quickly, it actually prevents implantation as well. Now, the copper, I guess the implanted device is made out of copper. How does that work? This primarily triggers an inflammatory response, and the inflammatory response will cause the cervical mucosa as well. So they kind of do the same thing, but with different mechanisms. Now, these both differ in how long they work. Mirena can work for about 5 years, whereas copper can work for about 10 years. And also, they also differ in the the effects. Mirena, because it has progesterone, it actually decreases bleeding and cramping. So this is ideal for a woman who's having really difficult periods and just prefers not to have it. Whereas the copper method will actually increase bleeding and cramping. And so this is generally been treated well with steroids. So you treat this with NSAIDs. And just to take a quick look at the actual device, here is the copper device. Let's make it bigger here. So as you can see, there's copper here and here around there, and then the Mirena device. Put it over here. The Mirena device looks like this. It's kind of has a plastic coating, and this will prevent fibrosis. So you just put that away. So those are your two implantable devices. Now these IUDs, what are some of their? Let's first talk about contraindications, because they do have some important contraindications that we need to make you aware of. The first primary thing is you have to rule out pregnancy. You can't give it to a pregnant woman, and so you do that obviously by checking the urine HCG. Secondly, any malignancy that may have, you need to rule those out, so such as leiomyomas, and this is why you might want to do a pap smear, for cervical cancer. Any type of infection, PID, endometritis, this is a contraindication, because obviously this is going to make it worse, and especially chlamydia in particular is kind of mentioned. And finally, for the absolute contraindication, any type of bleeding where you don't know you don't know the underlying cause. First fix that, and then go on to that. These are absolute contraindications. Relative contraindications, it is going to be some type of anatomical uterine anomaly. You want to use it either size or shape. Some type of heart disease. And the reason why they do this is because sometimes you can't get a perforation, and that may lead to bleeding, and then that's going to put too much stress on the heart. Or for example, if it does get infected, even though it's very rare, it can sometimes go septic, and someone with a heart disease wouldn't be able to handle it as well. So that's kind of that's why it's a relative indication, because those are very rare side effects, and any history of ectopic pregnancy as well. That's another contraindication. And finally, we can talk about the complications associated with IUDs. The first thing is going to be the actual expulsion. So, the lady can actually expel it from the vagina. And this usually, if it occurs within 1 month. So what this means is after 1 month, if they still have it in there, it's probably going to stay. There's going to be no issue. The other thing is going to be a perforation. And this is very rare, but it has been known to occur. Third is going to be an ectopic pregnancy. It can cause that. And sometimes there is associated infection. PID obviously, because it's in the uterus. And that usually happens within the first 2 months, or it won't happen. And finally, it can lead to an abortion if they're pregnant already. And that's why we check, for pregnancy before we get them started on this. So that's your two main IUDs, and these are going to be, again, your tier 1 contraceptive methods. So both of these have a less than 1% failure rate. The next tier 1 that we should discuss is going to be sterilization. Sterilization is permanent, and it's generally irreversible. Again, there are times if you really want to reverse it, it can be done, but pretty much, when you explain to your patients, it's irreversible. There's 2 types. First one is going to be the tubal ligation. And in tubal ligation, let me just draw quick, that's the fundus. This is the uterus, fallopian tubes, fimbria, and then cervix and vagina. So what you do with tubal ligation is you're going to clamp this here, or you're going to cut it up. You're going to do something in the tubal area, and that's going to prevent the actual ovum, the egg, from getting through and into there, and obviously it's going to prevent the sperm from going up. So from both ways it's protected. So tubal ligation is one way, and then the other way is to do a vasectomy. Vasectomies are a little bit more effective. This is going to be a 1 in 500 failure rate, whereas this is a 1 in 200 failure rate. Also, vasectomies are less invasive. This is going to be outpatient, and this is going to be either laparoscopically, so there's going to probably be general anesthesia involved. And also, very commonly, tubal ligation is done, after cesarean section, or if they're if they're opened up anyway. Sometimes they'll do it if there's a indication for it. Okay, so that's our intrauterine devices and sterilization, which makes up a bulk of the tier 1. We still haven't talked about DMPA and Implanon, but we will talk about that in a little bit. So next, let's talk about some tier 2. These are going to be your oral contraceptives. We'll just say hormones. So the tier 2 that we want to talk about now is going to be your hormonal methods. In this, there's 2 types of hormonal methods. There's the combined, and then there's the progestin-only. What are the differences? Well, in the combined, you can have the pill form, you can have a patch form, and you can have a ring form. And in the progestin-only, you can have a pill form, you can have an injection, and you can have an implantation, which is going to be implanting subcutaneously into the skin. I think before I said it incorrectly. It's actually subcutaneously into the skin. All of these generally have a failure rate of 2%. Here we have 3%, and this is going to be 1%. And yes, this is actually tier 1. And the rest of them are tier 2. So progestin-only actually has 2 tier 1, the injection and the implanted one. So how does it work? These hormones are going to act primarily on the pituitary gland. So it first works on the pituitary gland. It will have a negative effect on the pituitary gland, so it's going to decrease the LH surge. So there's going to be no LH surge. And let's just go ahead and here's your fundus, your fimbriae, your uterus and cervix, and your vagina, and then here you have your ovaries. Now, because you do not have an LH surge, there's going to be no ovulation, and also because there's no ovulation or anything like that, you start to get atrophy of the endometrium. So there's going to be atrophy here, and if you get atrophy, then it can no longer implant into the, say for example, if somehow there is an ovulation and you get a fertilization, the endometrium can't really sustain an implantation. And finally, it creates a very hostile cervix here, very thick and edematous, and that prevents the sperm from getting in. So from many different methods, by changing the pituitary hormone axis here, you are able to stop pregnancy. So first, let's talk about the combined methods of being pregnant. So let's go here. So the combined hormonal methods, we can call them. So we'll just put combined here. First is going to be the pill. Let's just talk about the pill. This is the most common, one of the most common methods. It's given in two. Oh, let's first talk about combined. What is combined? We can first discuss that. We're combining estrogen and progesterone. So that's why it's called combined, because we have both of these. Now in the pill form, you can start it on any day. So this can begin any day. So start any day. However, the effects won't start for 7 days. So for 7 days, you will still need to use other forms of contraception. Otherwise, they're still liable to get pregnant. Once you start it, however, and they start getting their menses, you have to start an on and off schedule. So you either do 21 days on plus 7 days off, or 24 days on and 4 days off. And in the off period, what is that for? Well, that is going to be for the withdrawal bleed, because you're kind of simulating the cycle, and so you need to give some time for the progesterone withdrawal. And there's, what they'll do is there's different ways with concentrations of progestin and estrogen. Sometimes they'll keep it consistent all the way through, and other times, it'll start off with a lot of estrogen and a little bit of progesterone. And as you go through the cycle, you're slowly going to increase the amount of progesterone that you have and decrease the amount of estrogen. It's not really that important to remember all of those. Now, what's really important about the pill is it actually can regulate the cycle. It can actually normalize the cycle, and it can make it more predictable. So, for some women undergoing breakthrough bleeding, like in PCOS and other conditions, this is one way to regulate their cycle. The next one is going to be in the form of a ring. This is called the Nuvaring. This is the trade name, Nuvaring. And so what this is a ring that's inserted into the vagina. And when it's inserted into the vagina, it slowly releases estrogen and progesterone. And so what you do is every 3 weeks, so you just remove every 3 weeks for 1 week. And so what it allows, again, you leave that 1 week so you can have the breakthrough bleed, you have that progesterone withdrawal. Also, some patients, when they're having sex, they can actually feel it, kind of bothers them. You can actually remove it during sex, but then it has to be replaced within 3 hours. So if someone's having issues with that, that's how they can deal with it. And finally, let's talk about the patch. So a patch is again, it's going to be slowly releasing estrogen and progesterone into the skin, and you can put the patch anywhere on the arm, legs, arm, abdomen, or the buttock, depending on where they prefer. Now this actually gives you about 60% more hormones than than pills, so 60% greater, and so then that's one of the reasons why they say it's slightly more effective. There is a controversy right now because they say that estrogen in general increases thrombosis, as we're going to talk about the adverse effects pretty soon. And so they say with the patch, because it's going directly into the blood, there may be a chance in that area having a slightly higher concentration of estrogen, and so maybe that area is a little bit more thrombogenic. So they've kind of thought about that, and they also said, when you take it orally, it has that first pass effect through the liver, and of course, if it's getting directly into the blood, that's not going to happen. So those are some ideas that people have put forward. Okay, so that's the combined. Now let's go on to the Progestin-Only types. So as I said before, there's going to be the pill form, and then there's going to be an injection form, and then an implantation form. So the pill, so in this system, in the combined form, it was 21 days on, 7 days off. Here, you just take one pill every day. So you take a daily pill, and it's continuous. Now, the other difference is with the combination form, it regulated the cycle. Here, actually, you get irregular bleeding, and this is called breakthrough bleeding. And breakthrough bleeding is just basically the bleeding is occurring after a while because of like unopposed or just thick uterus, and then finally the blood's going to slough off. So this is going to have irregular bleeding. So women who don't want that, who don't want irregular bleeding, to stick more to the combined. Okay, after this we have an injectable form. This is an injection form. What this is a specific form, and just so I can highlight, this is a tier 1, okay, whereas everything else is tier 2. And this is a specific form called dipomedroxyprogesterone acetate. So they use the DMPA as the mnemonic. This is going to be injected into the skin, and then what happens, it slowly releases the medroxyprogesterone, and this lasts for 3 months. So the woman doesn't have to worry about it for 3 months. And just like I guess all of these you can say is going to be irregular bleeding. So I'll write it here, but pretty much I can actually just write it up here, irregular bleeding, because these all experience breakthrough bleeding. Now the next one is going to be another form named Implanon. Now Implanon is going to be injected subcutaneously. It's a device that's implanted. Sorry, it's not injected. It's a device that's implanted subcutaneously, and it slowly releases etanogestrel. And it can actually be in the body for 3 years, up to 3 years. And this as well, I should just make it clear, this is a tier 1, and so then that means it's a less than 1% failure rate. So both of these are tier 1 and has a less than 1% failure rate. And so here, this is pretty much our combined in our progestin-only. So this is the hormonal one. I mean, with regards to tier 3, this is going to be condoms, diaphragm, and spermicide. Not much to be said. Oh, actually, sorry, before I finish, let's talk about some of the adverse effects of the hormones. Here you tend to get a few more adverse effects because, again, we're kind of messing with the hormonal systems of the body, and they have very far-reaching effects. So you have two types of effects, either the estrogen effects or the progesterone effects. Because they might be receiving one or both. So the estrogen, some of the effects that estrogen does. Oops, I don't know why I wrote 2 there. It decreases. Increases fluid retention, and this is particularly important for people undergoing heart failure. And the way it does that is it decreases sodium excretion, and so then that retains water. It can also be lead to exacerbation of cholelithiasis, which is your gallstones. Also, estrogen is known to increase the hepatic proteins, and these are proteins such as coagulation factor, which is going to increase thrombosis, as I kind of alerted to earlier. It can also increase carrier proteins such as thyroxine binding globulin and sex hormone binding globulin, and it can also increase angiotensinogen. Again, this is making it not great for people with hypertension. However, one of the better effects that it has is it can actually increase HDL and decrease LDL, which is something good because this is what we want. So it actually has a better profile for people with lipidemia, hyperlipidemia. And for progesterone, what does progesterone do? It can actually decrease serotonin. And so when it decreases serotonin, obviously this can lead to depression. So it's been associated with that. It does have some androgenic effects, such as weight gain, acne as well. It can also decrease your HDL and increase your LDL, so kind of the opposite there. However, this is better for lactating women. It doesn't interfere with lactation, so that's kind of one of the better things it's used for. And finally, let's go over some contraindications. When are times where you might not want to use these? There are, first thing again, pregnancy. You want to rule out pregnancy. You don't want to mess with that. Liver disease, like we kind of already alluded to, estrogen does affect the liver, so if they have any sort of liver disease, you want to avoid that. If they have any history of breast cancer, because breast cancer is something that's going to be will be worsened by estrogen, and migraine, especially if it's with aura. Now, so this is to one side. Then the other side has to do, the other contraindication has to just do with the fact that it's increased thrombogenic. So any smokers greater than the age of 35, see, smoking and by itself increases your risk of thrombosis. So if someone's a smoker and you add OCPs to it, hormonal, then it's going to make it even worse. So someone a smoker, you want to stay clear of these. Any sort of cardiovascular disease, such as cerebral vascular accident, stroke, hypertension, diabetes mellitus, or SLE, any of those vascular diseases as well, you don't want to mess with those. Now, there are other benefits. I think we can mention those as well. There are other benefits that are not related to contraception. So this can also be used for these reasons as well. One of them would be dysmenorrhea. It can actually help in that. Dysfunctional uterine bleeding, it can help regulate that as well. It has decreased risk of PID, ectopic pregnancies, and you have decreased risk of ovarian and endometrial cancers in the future. It also decreases acne, kind of what we alluded to earlier, and for some reason it decreases the risk of rheumatoid arthritis. So that's there as well. So that was broad two categories. Tier 3 I won't talk too much about. I think that's pretty obvious. But finally, what I will talk about is a topic called emergency contraception. So emergency contraception is for women who have had sex unprotected and they don't want to get pregnant afterwards. This is very common, specifically for ladies who might have gotten raped, and obviously they don't want to have get pregnant from rape. So there's 4 different types. One is the combination, estrogen, progestin. Second is going to be a progestin-only. Third is going to be an anti-progestin. And finally, there's actually an IUD, the copper IUD. So these 4 are your primary methods. All of them pretty much 3 to 5 days after having the intercourse is preferred. They all have variable failure rates. Copper is probably has the lowest failure rate of 1% again, if it's used within the first 5 days. Estrogen, progestin has about a 75% chance of preventing pregnancy. The progestin-only is you take 2 tablets of 0.75 milligrams of levonorgestrone. Can't read my handwriting, so you can double check that. So yeah, and then what you do is you take 2 tablets. So one of them you'll take within 3 to 5 days, and then so this is your first tablet, and then you take a second tablet 12 hours later. So this is the only one that takes 2 tablets, and the anti-progesterone that you'll be using is mifepristone. So this is the one that is being used there, and this copper IUD is the exact same copper IUD that we talked about when we talked about IUDs, and this is actually good because after so say for example, it's emergency contraception, she didn't want to get pregnant, and say she doesn't want to get pregnant again, well, right afterwards they're protected for 10 years from being pregnant again. So that's the discussion for contraception. I hope you found it beneficial, and I'll see you later. Bye.